You are listening to the Addiction Files, where we discuss evidence-based treatment, clinical pearls, and resources while striving to destigmatize the treatment of addiction in our medical culture and save lives. We are the Addiction Doctors, Dr. Darlene Petersen and Paula Cook. Welcome to the Addiction Files. We are excited to be back today, and we are talking about buprenorphine updates. There has been so many changes in this area, and it has evolved so much because of the amount and the changes in the landscape. And really, this is due to fentanyl use. So I'm going to turn it over to you, Paula, to talk about first high-dose bupe with the use of fentanyl. So tell us what has changed in this area. And I feel like if you listen to our older podcasts, you're going to just be like, what are you talking about? We don't use bupe that way anymore. But those were kind of our old protocols. But when you're dealing with fentanyl use, it's completely different now.
Exactly. You couldn't have said it more accurately, Darlene. Things have changed in the setting of synthetic opioid use because people have much higher tolerance than they used to. And also because of the lipofacility of fentanyl, we're having to adapt the way we treat opioid use disorder for people who use fentanyl. So we're going to talk about, initially, we're going to just talk about the changes in dosing of buprenorphine. So initially, Darlene, you and I were at the very onset of using buprenorphine in this country for opioid use disorder. I think we were there in residency, right, when we started using bupe. And we were taught to only use 8 to 12 milligrams, maybe 16 milligrams maximum dose for people. It was drilled into us that really there was no added benefit to dose anyone above 16 milligrams because receptor occupancy was maximized at 16 milligrams. Occasionally, you could maybe increase to 24 milligrams for maybe a 3% increase in receptor occupancy. But other than that, we should have no reason to go above to 32 milligrams or beyond. I don't think you or I dreamed of dosing anyone beyond 32 milligrams of bupe. And I don't think I ever had anyone on 32 milligrams of buprenorphine back in the day. Did you?
No, I think the max was 24 milligrams. And I can remember getting all these nasty letters from the insurance company about, what are you doing? This is so terrible for the patient. And you had to write all these justification letters. So it was a really interesting time for us.
Exactly. So now things have changed. And luckily, the research landscape, as you said, has been changing to follow up so that we can adapt to make sure that we are providing the correct treatment for people who are using fentanyl. So there's a landmark study that was published last year. It was first published in February 2025, but then published officially in Addiction Journal in June of 2025 by primary author Erin Stringfellow. The name of the study is The Association Between Buprenorphine Doses Above 16 Milligrams and Treatment Retention in a Multi-Payer National Sample in the United States, 2014 to 2021. This is a massively powerful study because it looks at huge number of people. It's an observational cohort study looking at insurance claims from 2014 to 2020, looking at 620 plus thousand episodes for about 500,000 patients who were dispensed buprenorphine naloxone for opioid use disorder. And what they looked at, Darlene, is the maximum daily dose of bupe in the first 30 days of the encounter. And then they measured outcome. The measured outcome was retention and treatment. And they looked at multiple durations, including 1, 3, 6, 12, and 18 months. And they looked at doses beyond 16 milligrams. They specifically looked at doses of 24, 32, and 40 milligrams. And what they found based on this data, and I remember this is like 500,000 people, this is a lot of people, is that daily doses of 24, 32, and 40 milligrams of sublingual bupe increased retention compared to 16 milligrams at between 1 and 18 months. They found that 32 milligrams was favorable to 24 milligrams at longer duration of treatment. So once people were 6 and 12 and 18 months out. And what was surprising to me, and I remember talking to my nurse case manager about this, was that 40 milligrams was favorable to 24 milligrams at the year and a half mark. So basically every time you go up in dose, the outcomes for retention increases. So when this study came out, ASAM did a little blurb on it and put it in their ASAM Weekly. I remember reading it and just going, oh my gosh, I'm underdosing people. And it makes so much sense because I have people who are coming back to me. We're trying to get them stable on from their fentanyl use, and they're still saying they're having cravings or withdrawal. And I have them on 24 milligrams or 32 milligrams, and they're still not feeling good. And there's even some data that even you have to go even higher than 40 milligrams. And so since this paper was published, I've changed my practice, and I've really started to push doses higher. And I'm amazed because I used to think that buprenorphine was not tolerable at higher doses. And I used to educate and counsel my folks that, okay, you might get a headache or you might get nausea. And I'm finding that exactly according to this paper, that people are tolerating it just fine and they actually need it. In fact, I just had a person who I was treating in the jail who's using raw fentanyl powder, and I had to escalate their dose to these high doses to stabilize them. So I think this is an important paper based on its power. I think we need to listen to our patients first. And this actually takes me back to several years ago when I was involved in the creation of an ER, emergency department bridge program in Salt Lake City. And we were thinking, we based the protocols on what the recommendation guidelines were at the time. And we were thinking, okay, people will need no more than 8 to 16 milligrams. And then I was in the follow-up clinic outside of the ED. And we were finding everyone coming in, and this was just at the time where heroin use was declining and fentanyl use was increasing. People were coming in and they were like, I used up my whole 7-day prescription in 2 days. I took 32 milligrams. And we were thinking, but why did you do that? You took too much. And now this makes so much sense. So bottom line, higher dose buprenorphine increases retention and treatment. Think 32 and 40 milligrams for people who are using fentanyl, and listen to your patient in terms of their symptoms rather than following a number. And we probably need to go back and take down our previous episode.
So one caveat there is the key is this is in light of fentanyl use. We still do some encounter patients with a prescription opiate abuse, and we do sometimes encounter patients with still just straight heroin use, although the use seems to still be quite high. And I don't typically see people needing quite those doses in those types of use. And then it seems to be kind of a fine line where you get incarcerated individuals with long periods of abstinence and past use. So their use is very intermittent. And so it's like you said, I think the key is listen to your patients, because if they've had 6 months, 8 months of abstinence or very intermittent use, you're not going to start them at 24 milligrams or something like that, but you may have to still go higher. So pay attention to them. I think
that's such an excellent point.
Yeah, that's such an interesting point and a really good study. Appreciate that.
No, that's a great point. And I thank you for saying that, because we still treat quite a few people with prescription opioid use disorder. And you're dead right. You have to start really low, conversely, and keep the dose low. So thanks for bringing that up.
This is such a rapidly evolving area that we are now in. Is what are we doing with these long-acting injectables? It's the same thing. This is an update to even our previous education, but I feel like they were so new and they came out and there were so many restrictions around them. And there's so many studies out that show that rapid induction onto long-acting buprenorphine is life-saving and improves retention. So let's talk about that, Paula.
Looking at the age of long-acting buprenorphine is really changing how we induce people onto buprenorphine, especially people who use fentanyl, is a huge update. And it's a very exciting update, all things payer considered, which you're going to talk about. Additionally, re-examining the use of low-dose micro-induction protocols, which, you and I have used for years as an attempt to get people eased onto buprenorphine. So let's talk about those updates. This is very exciting landscape. It's very exciting, like for me as a clinician developing a bridge program for the ED down here in my little rural town, thanks to some grant money. So let's look at who has laid the groundwork for this. And that's basically Gail D'Onofrio, who is a emergency medicine doctor at Yale. She has published this research with Andrew Herring, who's a doc out of California, looking at using injectable buprenorphine in the emergency department. Now, if you remember, Gail D'Onofrio is also the doc who really pushed and published the data on ED initiation of buprenorphine years ago and pushed the movement for the treatment of opioid use disorder with buprenorphine in emergency departments. In other words, improving access for people where they were presenting most commonly in crisis. So shout out to Dr. D'Onofrio. But this important study and this important work, and there's now lots of NIH-funded grants going on around the country, including one here in Utah called the Innovate Study, looked at using injectable buprenorphine to get people on bup without the use of sublingual bup first. So this was huge because we just didn't think we could do an injectable bup without first giving people sublingual for risk of precipitated withdrawal. However, sublingual bup, because it increases the serum levels of buprenorphine so quickly, really does induce precipitated withdrawal in people who are using fentanyl, because fentanyl sticks around for so long. We talked already about its high lipophilicity and people's tolerance to it. So backing up, Gail D'Onofrio published a study back in July of 2024 saying that she used extended release 7-day injectable buprenorphine, which there's only one brand of this medication right now. So I feel okay talking about the brand name, and it's Brixadi. They used Brixadi in emergency departments for people with mild opioid withdrawal. They looked at feasibility outcomes at the increase in cows of greater than 5 or cows going above 13 within 4 hours of giving that injection, or they looked at precipitated withdrawal within an hour. And then they also looked at secondary outcomes with giving the injectable, including pain, satisfaction, retention, and use of opioids at follow-up. And what they found was that precipitated withdrawal when they gave the injection was actually very, very low, only 3.2%. In participants who had a cows greater than 4. It was higher than that if the cows was lower than 4. So that's really important moving forward for developing protocols. But as long as the cows score was greater than 4, the precipitated withdrawal rate was actually really low. And satisfaction ratings were high. And the use of opioids moving forward after they got the injection was quite low, especially for opioid use folks, was less than 55%. And at 28 days, the retention onto the next injection, the monthly injection, was 73%. So this is an important study because it looked at when you could give this injectable, like when is it feasible to give this injection? They did the 24 milligram dose, which is equivalent to 8 to 16 milligrams. So it's important because from there, people have developed protocols and have been looking at whether or not we can actually do this without waiting for people to be in significant withdrawal from fentanyl and waiting for them to have a super high cows. And number 3, giving them a test dose of sublingual bup.
It brings up such an important point, like the risk of precipitated withdrawal, but we're balancing this against treatment dropout or overdose on the other side, right? That's what we're ultimately trying to prevent. Really interesting study in the JAMA Open Network. This was by Leslie Swin as the lead author, and this just came out in January 24th, 2025. And this showed initiation of patients using bup with improved retention. So this is what we're talking about. And I want to kind of highlight this using some patient vignettes of how this benefits it. So you have a 41-year-old woman with severe opioid use disorder presents to outpatient addiction clinic. She uses fentanyl daily, has failed multiple attempts at sublingual buprenorphine, and tells you, I need something that just works. Our older paradigm would have us delay injectable buprenorphine until she completes the 7-day transmucosal induction, which she's already failed multiple times. What does the current data say? So In this study, what it was is a multi-center randomized clinical trial. It enrolled 729 adults with moderate to severe opioid use disorder. They were randomized to rapid induction, 1 day of treatment consisting of 4 milligrams transmucosal buprenorphine, followed within hours by extended release injectable buprenorphine. Or they were put into the standard induction, which was 7 days of daily transmucosal buprenorphine before injection. What the primary outcomes included was safety and retention at the second injection. So that's what they're looking for, is getting them to the next month. The results that we want to look at is it was non-inferior safety between the rapid and standard. So there really was no difference between safety on that, but the higher retention in the rapid induction group. I think that's a key takeaway on this. Lower rates of precipitated withdrawal in both arms. So this risk of precipitated withdrawal was not seen in the rapid induction group. Consistent outcomes among fentanyl positive participants was a critical finding given the current risk of death with high rate of overdose death with fentanyl. Reframing this, that precipitated withdrawal is not eliminated by a longer induction with fentanyl, it's simply delayed. So the longer we wait, the more the patient has to disengage from treatment. And we're actually increasing their risk of overdose. Does that make sense? So you need to have this shift from withdrawal-centric thinking to retention-centric thinking. Does that make sense? So that's why our protocols should be shifting. So just some pearls I want to pull from this is thinking about our primary outcome, thinking about not a secondary benefit, engagement and continuity as primary outcomes. Fentanyl use is not a contraindication to rapid initiation, and extended release buprenorphine reduces adherence burden. So I think those are the 3 takeaways from that study. So those are the 3 pearls that I think you can pull out of that. All right. And I think you have 2 other studies, Paula, that kind of highlight that, or one other that we needed to go through. So I think, Paula, you had one other study on that.
Yeah, there's another study that was published in JAMA Network Open by Richard Waters in August of 2025. And this study is called Injectable Only Overlapping Buprenorphine Starting Protocol in a Low Threshold Setting. So as opposed to Gail D'Onofrio's work, which was occurring in the emergency department, this was an outpatient low threshold clinics, especially looking at people who are experiencing homelessness. And they looked at, this is a retrospective observational cohort study as well, and they looked at electronic health record data from September 24 to January of 25 in an urban low threshold voluntary OUD treatment program at a drop-in center. And mostly people, patients had moderate to severe opioid use disorder using fentanyl. And they were offered to have this protocol, which was an injectable only 3-day protocol. And they were given, so just slightly different to the protocol that Dr. D'Onofrio did. They gave them 3 days of injections. Day 1 was an 8 milligram weekly Brixadi injection. The next day, they gave them 16 milligram of the weekly. And then the following day, so day 3, they gave them a monthly long-acting injectable, either Brixadi 128 milligram or 300 milligram of Sublocade. They didn't require cessation of fentanyl. That wasn't the initial goal. And they didn't give any sublingual bupe. What they showed from this study is that 75% of the participants completed the protocol, which is really incredible considering the population especially, and 64% went on to receive a second monthly injection. So they went through the whole protocol and then came back a month later and actually got their injection. So I would be absolutely thrilled if we had that outcome in our clinic too. That's kind of what we're working towards, especially if it's folks who are really most vulnerable, like you've been saying. So there's multiple ways, obviously, to get the dose of the serum levels of buprenorphine up. This is a more aggressive method, definitely off-label. Not going to see this in the prescribing guide for injectable buprenorphine, but this study definitely demonstrated increased retention for people using fentanyl in a drop-in clinic, most of whom experiencing houselessness. And the main outcome was retention, actually completion of the protocol, and then 2 months retention, which was very, very good. So these findings are really promising, and they've certainly, much like the high-dose buprenorphine paper, all of this has really changed my practice in ways that I'm pushing to use direct to inject protocols. I'm borrowing that term from the San Francisco Health Network program. So both in my clinic, which I run a low barrier outpatient clinic, and then also developing a bridge ED program that we're now switching from a sublingual bupe protocol that we've been running for the last year and a half to a purely injectable protocol because of this research, because it's so much, well, I mean, it's for utility purposes, you can just give the injectable, excuse me, but also based on this data of reduced precipitated withdrawal risk, number one, and then increased retention, number two, therefore, hopefully reducing overdose mortality, this seems to be the way to go. So in terms of a protocol, which protocol to use, well, I think it really just depends on access. We could talk about access for a minute here in a minute, but it just depends on which protocol suits your population. I really like the San Francisco protocol. It's called Direct to Inject, and it was developed by the San Francisco Health Network Behavioral Health Service. It's available on the public domain, and they've done such an excellent job of describing it. They have printables, they have the protocol laid out, and basically what they do is they give, as long as the person has a COWS greater than 4, so again, based on Dr. D'Onofrio's study in the ED, showing that the risk of precipitated withdrawal is going to be 3% in that population, and the person has had no fentanyl use in at least 6 hours, they give the long-acting injectable buprenorphine weekly dose. And you can give any dose. They've described giving the 24 milligram dose, but we've given different doses based on what we ascertain the person's tolerance to be. We give and advise people write for adjunctive comfort meds because it takes about 24 hours for the weekly buprenorphine serum level to peak. So people may not feel very comfortable for that 24 hours while the buprenorphine levels are rising. And also as the buprenorphine starts attaching to the opioid receptors, maybe they don't feel super great. So we give adjunctive prescriptions of clonidine, hydroxyzine, ondansetron, etc. And then the protocol from San Francisco also advises giving supplemental buprenorphine in case the dose is insufficient to cover withdrawal and cravings to start 24 hours after the injection. And I found that to be true for this protocol as well. We're nearly always needing to give some supplemental buprenorphine to just cover our bases until we know if this dose of long-acting injectable is sufficient. So we normally advise, okay, wait 24 hours, see what you're actually going to feel the effect of this dose is for you. And then here is some sublingual bupe to take as a supplement in case you need it. And we give normally 2 milligram sublingual monoproduct tabs to take up to 8 or even 16 milligrams, depending on the patient. And then see them back in 24 to 48 hours after that initial injection. And we make a plan at that point to re-inject or to continue sublingual bupe. And of course, access to long-acting injectable buprenorphine is key for this whole protocol. But that is the protocol, assuming that you have access to the injectable. So in quick review, person has to have a COWS greater than 4, using fentanyl, so they have high tolerance. You give them, long-acting Brixadi weekly dose, give adjunctive comfort medication prescriptions like clonidine, ondansetron, maybe hydroxyzine, trazodone, depending on what your clinical judgment is for the patient. Give some supplemental buprenorphine prescribed as well, if you feel comfortable with that, to start 24 hours after the injection. Counsel them about the process and what they may experience, and arrange follow-up for 24 to 48 hours after the injection to see what else they're going to need. Are they going to need another injection? Do they need more sublingual buprenorphine? And obviously plug them into services. And based on this study, based on this protocol and what they're seeing, and hopefully you should have about 75% of your folks retained on buprenorphine at 30 days.
And I think that is fairly simple to follow.
It's super simple, and that's what's so nice about it. And I mean, we're going to talk about some of the challenges and barriers, but from a program implementer's perspective, like going from this kind of complicated protocol that we've had in the emergency department where, wait, cows this much, give this much sublingual bupe, cows this much, give this much sublingual bupe. Don't give sublingual bupe if they're not in withdrawal. Like, we've had some really significant precipitated withdrawal events for bupe being given too early in the ED and patients doing really poorly, to just switching towards if cow's greater than 4, go ahead and give the injectable bupe, has been amazing. And I've had a addiction medicine fellow with me, working with me this past month, and he's been really great at helping implement this protocol. And luckily, we have grant funding to allow this protocol to be implemented. Medicaid pays for injectable buprenorphine in my state. So that's very, very lucky. I know that's not going to be true for a lot of people and providers, but we've been able to implement this. And I know there's lots of studies around the country going on where long-acting injectable is available. But it's such an easy protocol, and we've been using it in the clinic. And we started doing this back several years ago in another outpatient low barrier clinic I was at, where literally out of desperation, I was giving long-acting injectable bupe for people who were just begging to try it. See, once again, the patients know best, because they had failed so many times to induce on sublingual bupe while they're using fentanyl, even though we had tried the microiest of induction protocols, Darlene, like dissolving little bits of bupe in water and swallowing it, and then they were still not tolerating it. I remember clearly one patient coming to me and saying, just give me that injection. Just give it. I take the risk. I assume the risk. I think I'm going to do just fine. I've had that injection once before and it didn't make me sick. And I was so worried about doing that. But he had been so sick by sublingual bupe while taking fentanyl, and we did it and it worked really well. So it's exciting to have the data to back this up. And do you want to talk a bit about the challenges and barriers in terms of payers and access?
Yeah, there's some true and relative contraindications. Obviously, hypersensitivity to buprenorphine or formulation components, that's the only true contraindication. While it's very rare, that would actually be a stop. Severe hepatic impairment is a relative. We're talking like Child-Pugh C liver disease level. The extended release bupe is hepatically metabolized, and so that is something you want to look at. But typically, we've got to understand continued use is contraindicated. So that's why it's a relative. But any kind of liver disease requires caution and close monitoring, or an alternative. That typically comes up on exam, so that's exam relevant. Inability to tolerate any transmucosal buprenorphine. So that's, again, a relative. All rapid protocols still rely on some degree of buprenorphine exposure. So this does not mean that they have to, again, you have to trial it right before it going straight to to injectable. But remember, very rare do we encounter a patient who's buprenorphine naive. But if you have someone who's buprenorphine naive, it is not the standard of care to give them an injectable. So that's not what we are saying. I just want to make that very clear. But this is making sure that this person has at least had buprenorphine in the past and that they tolerate it. So those are your relative. common misconceptions, not contraindications. Active fentanyl use is not a contraindication use. High opioid tolerance, not a contraindication use. These are the two places we want to use it, actually.
Right.
Precipitated withdrawal history requires planning, not exclusion. These protocols are written around that. And then housing instability. This is actually was what we're showing. This improves retention. So that's where it's great. Quickly, just on the payers. So we do run into that. There are, we are actually seeing, interestingly, in our state, very few are requiring these prolonged, like the traditional trial, which is the 7 to 14 days of transmucosal bup prior to switching to injectable, which is fantastic. I think they're catching up with the data, which is great. But we do still have one or two payers in our state, some of those smaller ones, and even a large one in our state that does require prior authorization, requires trial and failure. This is where use your knowledge, use your advocacy, speak to the medical director, send them these studies. And I have seen that work, Paula. We were the early adopters back in our day. Remember when we'd have patients like on some of these higher doses that truly needed it? And you had to do that. You actually had to make a call and advocate for your patients. That's sometimes what you had to do. I remember faxing in studies and had to say, look, this is the protocol that we're using. Here's the evidence behind it. This is why we're doing this. And you can sometimes get some wins there. It takes one at a time sometimes. It is very frustrating, but this is sometimes what you have to do in our field, I feel like. But it's a little at a time. Send this to your legislatures. This is what we're doing for you. Send this data to them, because this is what they need to know. Is this kind of stuff is life-saving. It improves what we have found. This improves retention and reduces overdose. So that's our two key pearls. And we need to take that shift away about that fear of precipitated withdrawal. So we have found that just giving people, requiring the transmucosal buprenorphine is just delaying with precipitated withdrawal. It's not preventing it. That's what that's our two take-home messages. And the long-acting buprenorphine is improving retention and it's reducing opioid overdose. So,
and it has higher patient satisfaction, which is also amazing.
Yeah, I mean,
inject, baby. That's the way to go.
There you go. All right. Thank you, Paula. That was fantastic.
Thank you.
Until next time. Hey, check us out at theaddictionfiles.com or email us at theaddictionfiles@gmail.com. Thank you so much to Ricky Valades for use of his song Awake. Check him out at rickyvalades.com.
Podcasts are for entertainment and education purposes only. Hosts and guests are not responsible for any harm caused by information obtained from this source. As each person is unique, you're advised to seek the advice of your own healthcare professional to treat any medical conditions you may be having. Opinions expressed on the show are those of the Addiction Files and not of our respective employers.